Okay, so today we're going to talk about anemia and go through neuro up to kind of midway through. Um, okay, so to start off, remember back when we talked about blood, there's different components. There's hematocrit, which is the percentage of red blood cells, and then there's also the hemoglobin, which is a separate, the molecule that carries oxygen around in the blood. So there are two different values that mean different things. So what's important about anemia is that it's a problem with your red blood cells. So this picture is just kind of showing your normal differentiation of those blood cells. So with reticulocytes, that's kind of like your early red blood cell, and so the more you have of these guys, the less mature red blood cells you have kind of floating around in the system, versus erythrocytes are your normal, what you think of when you say red blood cell. So with anemia, there's a faster push to crank out those reticulocytes, so the early red blood cells. And so the days spent as red reticulocytes, like there's many more cells that are reticulocytes in anemia compared to the regular count. And so you have this thing called the reticulocyte index, which is that count times this formula here. And it basically is saying that the bone marrow is trying to make red blood cells at a certain rate, because you need to like get more oxygen, and it's kind of like sacrificing quality for quantity, kind of. Serum iron and total iron binding capacity. So with this graph, it's showing you that there's different values for serum iron versus transferrin levels. So transferrin levels refer to the carrier for that iron, and so if you have low iron, so not much of the what needs to be carried, transferrin, so high transferrin, so lots of carriers but low saturation, they're not getting picked up by the carriers, by the high amount of carriers. That means iron deficient. If you have low iron but low carriers, then it could be normal saturation because it's kind of like a 1-to-1 ratio, but then it's kind of anemic of chronic disease. If you have normal iron, high transferrin, but it's not very well saturated, it's probably the liver problem has too much transferrin. You don't need that much. So iron is mostly bound to the red blood cells. The excess is stored in the liver, and so if you're low iron, are you iron deficient, you look at the transferrin levels, and from there, anemia, you kind of pick up iron as much as possible to keep it away from bacteria. Bacteria love iron for kind of their metabolism, and then transferrin is that plasma protein made in the liver. This graph, progression and manifestation of anemia, so it's just saying like some sort of problem with blood, decreased blood cell count, something like that. So either the blood is moving too quickly to pick up oxygen, or the heart is pumping too fast, and you can lead to cardiac failure. So there's this kind of like all what happens if you have low levels of oxygen and stuff like that. With the anemia problems, I would say like you have to familiarize yourself with the terminology. So try to break up these words a little bit easier for yourself. So like macrocytic, so macro, big, cytic, cell, like cytology or cytoplasm, that kind of thing. So big cell, normo means normal, chromic, color. So it could be big cell normal color. So that would be like the first problem. And so that would be your macrocytic normochromic megablastic anemia. So problems with DNA synthesis in this case. So it could be a B12 deficiency, where you have a problem with intrinsic factor. Folate would be a problem with alcoholics. Sorry. But in this case, it's like the cell is bigger than usual when it divides. Microcytic, on the other hand, little cells, hypochromic, less color. So the problem is with the hemoglobin synthesis. So you see small and pale red blood cells. And so that could be from iron deficiency, lead poisoning, sideroblastic anemia. So sidero is kind of a prefix for iron handling. So some problem with holding onto iron for sideroblastic anemia. Anemia of chronic disease, you're trying to keep away the anemia from the bacteria, and thalassemia is a genetic problem. Again, there's other types of normocytic normochromic disease, so it could be like red blood cell production is low, you could have high turnover of those red blood cells, or some other problem. So let's just kind of break it down. So megaloblasts of pernicious anemia. So with pernicious anemia, it's a problem. So so in this case, cells of the bone marrow replicate DNA slowly, and the daughter cells are bigger than they should be. This could be a vitamin B12 or a folate deficiency, so they kind of have very similar symptoms clinically, but kind of like internally there's a little bit of a difference. So parietal cells produce intrinsic factor that holds the B12. And so if you have a problem with the parietal cells producing the intrinsic factor, then that'll lead to a B12 deficiency, and you have this impaired RNA synthesis, and so that can lead to some form of B12 deficiency, which results in problems with your cell size. Folate also does kind of a very similar thing, but you see it in alcoholics, because folate is something that's used for neutralizing alcohols, and vegans are warned about vitamin B12 deficiency. You see it in like mushrooms and stuff like that, but it's vitamin B is also in like animal meats, that kind of thing, proteins. Hypochromic microcytic anemia of iron deficiency. So small pale red blood cells because you're iron deficient. The iron cycle. So iron isn't disposed of in the kidneys. So you have macrophages that phagocytose the red blood cell, they break up hemoglobin, they hold onto the iron, it binds to the transferrin, and it circulates back to the liver where it gets stored. Once it's stored, it can get picked back up by another hemoglobin molecule later, but if you have hemorrhagic anemia, hemorrhagic bleeding out, then you would lose that iron with the bloodstream that's bleeding out. Decreased oxygen content and is basically a big result of that could lead to anemia or other problems with red blood cells count and stuff like that. So it's just, you have low red blood cells, you have low oxygen content in your cells, so you have to make more erythropoietin to make the red blood cells. This will make, eventually make more red blood cells, and then if you make more red blood cells, then you decrease that erythropoietin. So feedback loop on the original. Aplastic anemia. The biggest term that's associated with that is pancytopenia. So it's a deficiency in all types of blood cells, so red and white blood cells. And so bone marrow does not make the red blood cells fast enough. So it's a kidney problem if you don't secrete enough EPO to stimulate the bone marrow, or it could be a bone marrow problem where the bone marrow itself isn't just converting into new red blood cells. Sickle cell anemia is when you've got these sickle shapes that they get into the capillaries, they get stuck, and they block other red blood cells, so they clog your arteries, clog your blood vessels, so they can't get through properly. And this is due to autosomal recessive trait. So sickling, basically, when the hemoglobin stacks up, it can occlude those capillaries, and when it blocks the capillaries, you get even more sickling. If you get more sickling, you get ischemia and decreased blood flow. So it's a very difficult problem to deal with. This graph, so sickled cells are cleared by the spleen. So the spleen is where all old red blood cells go to get filtered out and die, basically. But these sickled cells, they can go through, but because they're all spiky and stuff like that, they kind of damage the spleen as they're going through. So then eventually your spleen can't filter those red blood cells very easily, and then it starts to get degraded bit by bit. And then sickle cell disease can affect any place that blood can get to. Beta thalassemia, so hemoglobin is made up of 2 alpha 2 beta subunits and 4 heme molecules. So if you lose like your beta component, you get a little bit more alpha, and then the alphas, they kind of look like betas, and then they kind of all just get stuck together, and you don't really need to know like the biochemistry of it or anything, but basically what happens is iron gets taken up really aggressively and you have an iron overload, and so with that iron overload, you kind of need more blood and stuff to kind of deal with it. Hold on. So you have increased iron stores here in the liver, and then iron overload, so you try to get rid of the iron somehow. But also, because you're not very able to circulate oxygen in your system from the anemia, you kind of start breaking down bones, and if you can't break down any more of your other bones, then you could even take bone marrow from the skull if it gets to that point. Sickle cell affects many different regions, but mostly kind of these regions we see the sickle cell trait popping up because it's protective against malaria. So these people have one copy of the recessive, one copy of the dominant, so they have a heterozygous advantage. Spherocytosis, so this basically it's like these, for some reason these red blood cells, they don't like normal shape, and so there's a defect in the skeleton, so blebs kind of come off as pieces, and eventually you get to this perfectly spherical shape. So it's got a very like conserved surface area to volume ratio, just to kind of keep it as good as possible. Spherocytosis, you'll see these like circularly shaped things, and you also see what's also called the Howell-Jolly bodies. So there's small dark nuclear remnants. They're kind of like these black dots that you see in the red cells, and so that will show up on clinical cases if you see it. So that's kind of characteristic, these Howell-Jolly bodies. You have this other thing called a Heinz body that you see with the glucose 6-phosphate dehydrogenase deficiency, and so with this, this enzyme is part of your antioxidant machinery, and so it breaks down things like that cause some sort of oxidative stress to your body, and so it protects your hemoglobin. And so what happens is your cells, they look like they've been chewed out, because a macrophage, they see that you have these accumulations of aggregates of like different forms of damage and like debris and denatured things, and so a macrophage will come and like kind of pluck out these like aggregates, and then when they pluck out the aggregates, it kind of looks like it took a bite out of the red blood cell, and so it starts to look like a Pac-Man shape. So this glucose 6-phosphate dehydrogenase deficiency, Heinz body, denatured globulins that get taken out by the macrophage, look like Pac-Man. Yeah, bite cells. Microangiopathic hemolytic anemia, seen with DIC. So this is commonly associated with hemolytic uremic syndrome, and so you've got a fibrin mesh that kind of fell over your reticulocyte, and the reticulocyte kind of like was able to escape free from the fibrin mesh, but in the process it got a little chopped up. So the hemoglobin floats around in the blood, and it leaks through the basement membrane in the kidneys and causes damage, and so you're decreasing the glomerular filtration rate, and you cause uremia. The kidney could or could not be permanently damaged, and then E. coli can sometimes outbreak in children and patients. Myelofibrosis, so it's a bone marrow problem, so collagen replaces that bone marrow, so your cells start to look pinched, and they kind of seem like scar tissue, because they can't really squeeze through the blood very easily, and so when they squeeze through, it kind of looks like they're getting clamped, so it's not as easy for the red blood cells to get moved through, so they look like teardrop shapes. Then we've got hemolytic disease of the newborn. So this is a problem if you have an Rh negative mother, Rh positive child, And so the first child, the blood is separate from the fetus and the mother, so there's no antibodies in Rh negative against the Rh positive factor. But then once the mother has the baby, there's a lot of mixing of blood, and so her negative blood gets exposed to the positive, so she starts developing antibodies against it. And once she's got the antibodies against it, the next time she has a child, the second child with the Rh positive factor would get attacked by her anti-positive antibodies. So they give her like a drug called Rogam and other therapies to make sure that her immune system doesn't attack the fetus second time around. This graph I kept on my cheat sheet just because it was broken down pretty nicely. Shows you a picture of everything, and like you can just kind of write everything in, and if you have any questions or like notes about each individual thing, it's good to review with them. So just to review, macrocytic, normochromic, that was your big red blood cells, normal color. But that's because of B12 deficiency, which is that pernicious anemia, or it's a folate deficiency, and they look very similar. Microcytic, hypochromic, that's iron deficiency, sideroblastic anemia, or chronic disease, or beta thalassemia, so it's small, pale red blood cells. Normocytic, normochromic could be these problems with actually making the red blood cells, or it could be a high reticulocyte index when you have a high turnover. So it could be sickle cell, hemorrhagic, or hemolytic anemia. And then you've got the spherocytosis, remember the blobbing off, the glucose 6-phosphate dehydrogenase deficiency, so that's with the Heinz bodies, they look like fight cells, and then the microangiopathic hemolytic anemia, which we just saw. So polycythemia is an increase in all the types of red blood cells, and you get viscosity of blood because there's too many. Moving on to leukemia. So just remember with the prefixes, so cyte means cells, cytosis or philia, those are for too many, and then penia or penia is typically your too few. And then so we're going to talk about different types, so ALL, AML, CLL, CML. So you don't need to know anything specific about this, it's just showing you how a progenitor kind of precursor cell becomes and branches off into all of these. And then acute problems of leukemia are typically higher up on this chart, and then chronic are typically lower on the chart. It's just something. So anemia, you have fewer red blood cells, bleeding, fewer platelets, infection, fewer leukocytes if it's like a problem, and then you could have elevated uric acid, and then you could have weight loss, cancer problems. So acute leukemias, they have immature red blood cells, typically worse survival in adults but more common in children. And so you have what's called the Philadelphia chromosome, which is a translocation between chromosome 9 and 22. So remember, translocation is that unequal crossing over, unbalanced crossing over. And then AML, on the other hand, is the most deadly leukemia, 1% of all cancer deaths. Affects a wide age range, and then it can have many different subtypes. Chronic leukemias, so chronic lymphocytic leukemia is B-cell problem, so that is associated with hypogammaglobulinemia. So you produce antibodies that never find the same antigen, and so these B cells, they really don't do anything, so you've got too many of these B cells that are just kind of useless. And then you've got chronic myelogenous leukemia, and so this again is with the chromosome 9 to 22 translocation Philadelphia chromosome. So very poor survival in young adults. And so these are more mature red blood cells that have the chronic leukemia problems. So chronic myelogenous leukemia, so many white blood cells that none of them actually get fully mature. Multiple myeloma affects it's one plasma cell that becomes cancerous, and you have hypergammaglobulinemia, too many antibodies that don't really do anything, and you can have bone pain, infections, high albumin count, high antibody concentration, and low serum albumin. Anemia, you can have this Bence-Jones proteins, which are the IgG light chain in the urine and renal failure, so that's something that's special that you might see in a clinical case. Bence-Jones proteins, and then antibodies get stuck in the basement membrane of the kidneys, immune system starts to act up, and then so the antibodies get reabsorbed and cause tubular interstitial damage, which leads to proteinuria. So antibodies are stuck, immune system attacks, they're reabsorbed, and then they cause some damage, and then protein kind of leaks out. Lymphadenopathy, so that's, it's not an infection, but you get enlarged lymph nodes, enlarged germinal centers, and an increased B-cell count. And then Hodgkin's lymphoma has these Reed-Sternberg cells, which are the unique component to Hodgkin's lymphoma. And if you don't have the Reed-Sternbergs, then it's non-Hodgkin's. But the non-Hodgkin's can be like a bunch of different types. Whereas the Hodgkin's, it's just like the specific, like spreads continuously and stuff like that. And then Hodgkin's lymphoma can affect all of these different parts, and that's pretty much it. Yeah. So now we're gonna move on to neuro. So with neuro, so strokes, there can be two major types of strokes. One is the ischemic stroke, and one is the hemorrhagic. So with the ischemic stroke, remember that TPA, which is the tissue plasminogen activator, it can break up clots, and so you want TPA to break up clots to prevent an ischemic stroke, because then you can like have good blood flow again. But if you give TPA to someone who has a hemorrhagic stroke, so bleeding out, then you cause them to not be able to clot, and so they bleed too much. So strokes, ischemic strokes, TPA is good. Hemorrhagic, don't use TPA.
What would you use for the hemorrhagic?
Oh,
I can't remember if he said, like,
I don't think he
okay.
I don't think he said.
Because I think he kind of just skipped over that. But
yeah, I think
okay.
it's like once you kind of have like brain bleeding, that's kind of
yeah. Okay.
Arterial distribution to the brain. There's not too much anatomy that like he goes into like in class, but the circle of Willis he likes to talk about. Let's see, the left middle cerebral artery is a good place for, is a popular place for strokes. Like your cerebral artery, because that's kind of where like a lot of, I don't know, just for some reason strokes happen there a lot. These are just different brain views. I'm not going to run through it. Hemorrhagic strokes, I think, are kind of towards the bottom of the, under the middle cerebral artery, a little bit like this area, I guess. Don't know how to describe it, but yeah. So, brain infarctions, yeah. Okay. Okay, here's something better. So dysphagia. So dysphagia is like a problem with speech. So Broca's area. So Broca's area is responsible for kind of like the muscle coordination involved in speech. So if you affect Broca's area, you have difficulty speaking and writing. It's like the actual movements associated with the actual like communication. Wernicke's area, on the other hand, is more for like the actual content of language. So like if you have a problem with Wernicke's area, instead of being able to say cat, you might say dog or chair or hat or flag or something like that. Global frontotemporal, that's in the very front of the brain, and so that part, you could have impaired language. Anomia is a problem with the angular gyrus, or the posterior superior temporal part. So the posterior means like kind of in the back, superior meaning like higher up, temporal is on the sides, it's kind of like this area. So you could have a problem with anomia, inability to name objects. It's near Wernicke's area. Transcortical motor, anterior presylvian fissure. So a lot of these have a lot of different like classifications because there's so many regions that like if you picked up the brain they all kind of look the same, so you have to be very specific like kind of regionally. So here's the sylvian fissure. So transcortical is kind of in the front. So a good way to remember that motor is kind of in anterior is if you were to hear like a bear, like imagine you're outside at night in the forest. You hear a bear, but you like hear it from behind. So that's the sensory. You sense it from behind. But then you instinctively run forward. So you use the front of your brain and you just run forward. That's the way I remember it. So the back posterior side is the input, and then front is the output. Intracranial aneurysms. So if you have a blood clot in the circle of Willis, you increase pressure, and that pressure, it can damage the brain. And when aneurysms rupture, it's like a super stroke. So a lot of blood and a lot of bad things. So this circle of Willis is very important. I don't know if he asks you like what are the components of it, but this would be good to just familiarize yourself with the concept of the circle of Willis and like all these different major arteries that kind of branch through around here. And so when there's a problem with the circle of Willis, there's a lot of strokes and other bad problems. Arteriovenous malformation. So it could be congenital, or if the surgery went bad, and it could rupture if there's increased pressure in the venous system. So if you remember back, arteriovenous anastomosis, so that's the only like natural connection where the artery vein kind of is direct, and that's when you want the skin to cool. But in this case, it's not very good because it's very easy for it to rupture. Surgically, you just have to remove it. Herniation and increased intracranial pressure. So the tissues, when they hernia is moving a place where they shouldn't be. So you could have a subfalcine herniation, which is this herniation of the cingulate gyrus under the falx cerebri. And the falx cerebri is the gyrus closest to the corpus callosum. So the corpus callosum is like this like little circular part that connects left and right hemispheres of the brain. And so the falx cerebri is like literally like right under, kind of, I guess. And then, or it's the gyrus closest, so it's kind of like this area, I guess. Herniation of temporal lobe into tentorial notch. So it could go hernia that way, and that's called uncinate herniation. And then lastly is tonsillar herniation, downward displacement up through the brainstem. Hydrocephalus, so it's a problem with too much fluid in the ventricle, so the ventricles enlargen. So you could have non-communicating versus communicating. So with non-communicating, you make the CSF and it drains through the cerebral aqueduct, but it clogs and compresses the plexus, but it keeps making more and it's just not draining. So this problem is a drainage problem. And so to treat it, you shunt it off, and this problem is seen kids with big heads, normal intelligence, but it's a problem for adults because adult skulls don't accommodate the larger brain. Communicating hydrocephalus, so the CSF gets reabsorbed in the midline of the skull around the arachnoid granulations, but if it's not reabsorbing properly, then there's too much CSF everywhere else, and it's usually seen in older patients. and that's due to like a damage to the arachnoid granulations. And so you bleed into CSF, and the arachnoid granulations get damaged. So communicating, problem with reabsorption into these arachnoid granulations, and then non-communicating, problem draining it out with this through the cerebral aqueduct. So communicating hydrocephalus occurs when the flow of CSF is blocked after it exits the ventricles. It's communicating because CSF can still flow between ventricles, which are open. Non-communicating is also called obstructive because the flow of CSF is blocked along one or more of the narrow passages connecting the ventricles. Yeah. Okay, so that's a picture. Alright, hydrocephalus. You'll see like someone has like a relentless headache that doesn't go away, decreased mental function at times, can't walk, lose bowel control, could go unconscious because there's so much intracranial pressure. Trauma. So if you break the middle meningeal artery, it feeds almost all the meninges and the dura mater. So an epidural hematoma. So the patient comes into the hospital that didn't damage their brain, but blood forces brain through the foramen magnum, and then a herniation occurs in their sleep, and the patient dies within the hour. So it's kind of like when you see trauma patients, you have to check if there's an epidural hematoma to make sure that like you might not see it initially, but you have to like do the CT scan to check their head to make sure there's like not an underlying problem when they just go home. And then a ruptured aneurysm could cause bleeding without trauma, and same with a parenchymal bleed that leads to a hemorrhagic stroke. So epidural hematoma, like epi higher up, traumatic brain injury. So you've got a skull and the CSF for your two layers of protection. Spinal cord injuries are very difficult as well because you could like attack here, bang there, and then that could cause some sort of fracture. Spinal cord trauma, axons in the spinal cord are not replaced, but are in the ankle. So typically, like you'll have this like let's see, this one. So like your axons could, in theory, reconnect, but because there's so much that could block the pathway when it's like growing, then it could just get cut off, and then it eventually would like miss each other, and it wouldn't really regrow properly. And then degenerative disc disease. So there's two parts to this. So you got what's called the annulus fibrosis, and that's the rubber band kind of part around, and that's strong under tension but useless under compression. So I can stretch a rubber band, but if I push down on it, there's really nothing it can do. Versus the nucleus pulposus, which is the springy goop stuff on the inside. And so if the goop leaks out and hits the spinal nerve, you get paralysis. So that's degenerative disc disease. Cancer, you've got gliomas, astrocytoma, glioblastoma, oligodendroglioma, ependymoma, medulloblastoma, meningioma, schwannoma, and metastatic. So intracranial tumors, so they can grow, they increase pressure, displace your brain material, you get a headache. Papilledema is a sign of intracranial pressure, and it's like this bulging that you feel, and the bulging in the foramen magnum near the optic canals. So it's just, and then so basically, cancer leads to pressure, pressure leads to many problems that can cause altered brain or altered behavioral function. This is a picture of an enlarged ventricle, hydrocephalus, headache, again. Metastatic, typically not survival, or it is not survival as of now. Spinal cord tumors, very difficult as well. Very different parts that they affect. Bacterial infections. So bacterial infections usually are not in the brain because it's difficult for bacteria to get into the blood-brain barrier. But you could have one case is meningitis though, which is very very difficult to deal with. The axons typically don't really go here. Viral infections are very very difficult. And then you've got a prion infection. So this is not a virus, and it's also not like a living organism as well. It's a protein, kind of like a quote-unquote protein virus type thing. And so the protein, what it does is it will bind to another protein, and it'll induce a conformational change. So that other protein can no longer do what it normally does, and then it starts to aggregate. And when it aggregates, that's when you've got the problems in the body. So the typical cases are mad cow disease, or there's like one called Kuru, which is in like certain indigenous tribes because they eat like brain tissue and stuff like that, but not as common. And then there's the most famous one is Creutzfeldt-Jakob disease. And now we're on to degeneration. So with degeneration, we've got Alzheimer's disease. So it's a very specific form of dementia, and it's specifically pre-senile dementia. So the gyri become much thinner, cell site much wider, and you form what's called amyloid plaques. So that's it's basically like you have these aggregates in the cell that you couldn't really deal with, and because you couldn't get rid of them, they start to aggregate together. So dementia, there's two types. There's anterior grade, so you have trouble making new memories. So it's like the movie 50 First Dates. So like you could play Scrabble, but you couldn't play a new game called Mexican Train Station. But then retrograde amnesia, you lose your old memories. It's very very rare, and you can't play Scrabble because you don't remember them. Alzheimer's gets both, and like older people just have like the anterior grade. It's just they remember the old stuff though. So these amyloid plaques deal with these like alpha beta components of this certain transmembrane protein, and they're supposed to be normally just cleaved and like dealt with, but because they're not properly cleaved, then they start to just connect together and form these plaques that they like can't diagnose this until like post-mortem, but then like Georgetown recently came out with that article about like finding a new way to detect Alzheimer's. And so you lose blood flow because of these plaques cutting off the blood flow, and then the neurons start to die, and then memory problems set in. And then you've got these major motor system diseases, and then I put this on my cheat sheet just because I wasn't sure if any of this would help. I'm not sure if it actually did, but if you had space, like, there's a lot of words here,
Yeah.
you never know. But basically it's just breaking down, like, you could have a motor problem, you could have a problem, like, in the back of the head, in the brainstem, in the spinal cord, in the actual nerves, like, sensory nerves versus motor nerves, primary muscle, anterior horn, bulbar. So you've got these two things, lower motor neuron versus an upper motor neuron. So it's like you have to go through both to get to your like what you're actually like the action. So like the way that your neurons are all organized is that they're all hierarchical. So like one neuron goes up through this much of the body, then this from like up to the spinal cord, this from spinal cord up to the brain, brain up to the thalamus specifically for like higher control and stuff like that, and then same with the output. So it's a lot of tracks in between. And then Parkinson's disease is a problem with the substantia nigra, and so that's responsible for making so substantia nigra is black because of melanin, a type of melanin that it produces. And so you got dopamine, which is responsible for rewards and like decision making sometimes, and sometimes motor kind of coordination. And so when you damage when the substantia nigra no longer produce the dopamine effectively, then you don't really get the rewards, and you don't get like the decision making as clear, and you have trouble with like coordination. And So you have what's called dysdiadochokinesis. So it's the inability to start and stop. And so neuromelanin problems, so you don't have like the black melanin, don't have the dopamine. You can have a resting tremor and smooth movement. And yeah.
Yeah, that was where we
Stopped. Cool. Let's see. So it's 5:50. Do you want to just end here? Do you want to finish out?
I mean, it doesn't matter depending on if you would rather just finish out.
We can just finish off.
Okay, yeah.
So Huntington's chorea, you'll learn is the kind of like the opposite of Parkinson's, because it's like you have excessive output and it's always twitching, always like jerking movements, versus like the Parkinson's, it's like inability to start, stop. This is like you're constantly like doing something. And then Huntington's is autosomal dominant, so if you have one copy, you will get the disease. And then multiple sclerosis, you can have 4 different types of progression, so relapse, remitting, progressive relapse, primary progressive, and secondary progressive. And so these are all just different forms of like how the disease progresses. So multiple sclerosis is a demyelinating disease of the CNS. So the immune system attacks your oligodendrocytes, which myelinate the axons. And so if the axons don't have myelin sheaths, then your signal, your like action potential signals, don't really jump. They don't have that saltatory conduction anymore, so they can't move as easily. And so like sometimes you might see like a clinically like right leg weakness only, and it's not bilateral. It's like one problem because of like one problem in the brain or something like that. And most people are diagnosed with a sensory or a muscle weakness and not correctly that. Then you've got different types of myelination going on here, and then so you could have normal, segmental. So with segmental, you see how it's just like just kind of broken up, and then axonal degeneration, like so the axon itself just doesn't even really stand a chance. Demyelination, remyelination, so you got Guillain-Barré is an autoimmune system disorder, which is affects the peripheral myelinating cells, which are called the Schwann cells, and they get destroyed and they form this characteristic onion bulb neuropathy shape. And that's it.
Okay.
Great.